Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. So in this lecture, I will be explaining you Sphingolipidosis. Let's get into the details. Alright, now let me explain you briefly how exactly the stepwise degradation of the sphingolipids happens in the lysosome, especially lysosomal acid dehydrolysis. So, here in this molecule, there are two neuraminidase acids being present. So, the neuraminidase enzyme is going to remove one of the neuraminidase acid and release it. And the remaining molecule we got now is GM1 ganglioside. Now, the beta-galactosidase enzyme is going to break a bond, beta bond here, and release galactose. And the rest of the molecule now we have GM2 ganglioside. And in this GM2 ganglioside, N-style galactosamine, which is present here, it will be removed by beta-hexosaminidase A enzyme. Now, what is left over is a GM3 ganglioside. So, GM1 is converted to GM2, GM2 is converted to GM3 now. So, GM3 ganglioside, which has got N-style neuraminidase acid on this side. So, now again neuraminidase enzyme comes and removes that N-acetyl neuraminidase acid, that is NA. Then we have ceramide with glucose and galactose, which is a lactosyl ceramide. Also note that from the other side, say from here, from down here, globoside, so which has ceramide, glucose, galactose attached with N-acetyl galactosamine, which is handled by beta-hexosaminidase A and beta-hexosaminidase B enzyme here, where globoside, it is from the globoside, there will be removal of GalNAc. And now we have ceramide, glucose, galactose. And this ceramide, glucose, galactose, it is a ceramide trihexoside. And this ceramide trihexoside, it is catalyzed by alpha-galactosidase A enzyme and remove one of the galactose. One of the galactose is released. And what we got now is ceramide, glucose and galactose. Okay. Now, this ceramide, glucose and galactose containing globoside molecule, it is catalyzed by beta-galactosidase enzyme and release a galactose from it. Now we have ceramide plus glucose, which is a cerebroside called glucosyl ceramide or glucocerebroside. So the glucose will be removed from the cerebroside. So that is done by beta-glucosidase enzyme. So glucose is released. Now what is remaining is ceramide. Now the ceramide is separated into sphingosine plus fatty acid done by ceramidase enzyme. Ceramidase enzyme or ceramidase enzyme. That's how ceramide is broken down into sphingosine and fatty acid. So sequentially, one of the component is removed by a specific enzymes here. That's how a sequential degradation of a sphingolipids will be going on in the lysosome. All these are lysosomal acid dehydrolysis. Alright. So on the other side, as you see, we have sphingomyelin, that is ceramide with phosphocholine is a sphingomyelin. Sphingomyelinase enzyme is going to release a phosphocholine and ceramide is separated, and ceramide will get into ceramidase reaction separated into sphingosine plus fatty acid. On the other side, like sulfatides, which are richly present in the brain, especially in the myelin sheath. So we have ceramide, galactose and sulfate, which is attached, and that sulfate will be removed by aryl sulfatase or sulfatidase enzyme. So once the sulfite is removed, so we have ceramide with galactose, and that is now further metabolized by beta-galactosidase enzyme, where galactose is separated, ceramide is released. So like this, every sphingolipid is degraded in the lysosome whenever a normal cell turnover is going on. Now, the purpose of understanding this lysosomal degradation of sphingolipids is if there is any defect anywhere in this degradation pathway, it will lead to accumulation of specific sphingolipid in the tissues, and that will give rise to a type of disorders called as Sphingolipidosis, excess accumulation of sphingolipids in the tissues. So now let me give you some points with what I have explained so far. So sphingolipids are normally degraded in reticuloendothelial system located primarily in the liver, spleen and bone marrow. Degradation happens in the lysosomes of phagocytic cells, especially the histiocytes or macrophages present in reticuloendothelial system of liver, spleen and bone marrow. Note that ganglioside turnover is highest in the brain, particularly this happens in the neonatal period. That's why if there is any defect in the degradation of sphingolipids, it will lead to severe neurological condition. Alright, so the lysosomal acid hydrolases, they catalyze all the reactions involved in glycosphingolipid degradation within the lysosome, and decreased activity of these lysosomal acid hydrolases will lead to accumulation of partially degraded glycosphingolipids in the lysosomes of different tissues, and that group of disorders we refer them as Sphingolipidosis. Now let me explain you with the again degradation pathway. Just in brief, what are the different disorders that can be found because of defect in lysosomal acid hydrolases, giving rise to different types of Sphingolipidosis. So the slide here is showing you different Sphingolipidosis, especially at different stages of glycosphingolipid degradation pathway. So as you see here, GM1 gangliosidosis, it is because of defect in beta-galactosidase enzyme, where GM1 ganglioside is not degraded completely. So that's why there will be accumulation of GM1 ganglioside in the tissue. That is why the name of the disease is GM1 gangliosidosis. We will go over details of each and individual disorders in later slides. Now the second disease that is mentioned here is tay-sachs disease, and the tay-sachs disease is because of deficiency of enzyme called beta-hexosaminidase A enzyme, which is responsible for removal of N-acetyl-galactosamine from GM2 ganglioside by breaking the beta bond, right? So N-acetyl-galactosamine is not removed, so GM2 ganglioside just accumulates in the tissue. That's why tay-sachs disease is also referred as GM2 gangliosidosis, because there is an accumulation of GM2 ganglioside there. Similarly, on the other side, we have Sandoff disease. The Sandoff disease is because of deficiency in both beta-hexosaminidase A enzyme and also beta-hexosaminidase B enzyme. So because of the deficiency of both the enzymes, so there will be accumulation of GM2 ganglioside and also globoside. So in this disease, because two enzymes are being defective in Sandoff disease, one is beta-hexosaminidase A enzyme, as you see here, it is in degrading GM2 ganglioside, and the other is beta-hexosaminidase B enzyme that is taking care of degradation of globoside. Both of them are deficient. That's why in this disease you are going to see elevation of both GM2 ganglioside and globoside. That's the difference between tay-sachs disease and Sandoff disease. In tay-sachs disease, there is accumulation of only GM1 ganglioside, whereas in Sandoff disease, there is accumulation of both GM1 ganglioside and globoside. You need to remember that difference there. Now, coming to Gaucher's disease. Now, in Gaucher's disease, there will be defect in the enzyme called beta-glucosidase, which is also called as glucocerebrosidase. And this enzyme, it is going to release glucose from ceramide. So, because of the defect in the enzyme, so there will be accumulation of glucocerebrosidase. That's what we are going to see in Gaucher's disease. And then on the other side here, Fabry disease. Fabry disease is because of defect in alpha-galactosidase enzyme, which is catalyzing the breakdown of ceramide trihexoside. That is ceramide containing 3 hexoses. And that doesn't go on, so there will be accumulation of ceramide trihexoside in Fabry disease patients. And then niemann-pick disease is because of deficiency in sphingomyelinase enzyme, which is converting sphingomyelin into ceramide plus phosphocholine. So there will be accumulation of sphingomyelin in neuronal tissue in niemann-pick disease. And then the conversion of ceramide into sphingosine plus fatty acid done by ceramidase enzyme, and that is, if that enzyme is deficient, so it will give rise to Farber disease. Then on the other side we have sulfatides, which contain ceramide, galactose and sulfate, and aryl sulfatase enzyme is removing that sulfate and converting sulfatides into galactosylceramide. Furthermore, beta-galactosidase enzyme releases galactose from galactosylceramide and makes ceramide. So in this pathway, if aryl sulfatase enzyme is deficient, it will lead to accumulation of sulfatides, and that leads to metachromatic leukodystrophy. Whereas in beta-galactosidase enzyme, where it is handling galactosylceramide, if that enzyme is deficient, it will give rise to Krabbe disease. Like this, defect at various steps in sphingolipid degradation will give rise to variety of sphingolipidoses. So here is the table which is enumerating all the sphingolipidoses with the enzyme being deficient, lipid being accumulated in the tissues, and also some of the clinical signs and symptoms. Let me briefly go over this, then we will go into individual disorders. So we have a tay-sachs disease where there is a deficiency of hexosaminidase A enzyme, which is also a beta hexosaminidase A enzyme, where there will be defect in the removal of N-acetyl galactosamine. Remember that, sometimes that can also be asked, what is not removed? It is N-acetyl galactosamine not removed. Thereby, there will be accumulation of GM2 gangliosides, and patients will show mental retardation, blindness, muscle weakness. We will go into details later. Fabry disease is because of deficiency of alpha-galactosidase enzyme, so that leads to accumulation of globotriacylceramide, which is also referred as ceramide trihexoside. This is the only X-linked recessive condition in sphingolipidosis, so that helps in the diagnosis process, at least in the case stem or in the question. And the metachromatic leukodystrophy because of deficiency of aryl sulfatase enzyme. So sulfatides are most abundant sulfatides are sulfogalactosylceramide. So patients again will have neurological issues, demyelination process and all that. Krabbe disease is because of deficiency of beta-galactosidase, where this galactosylceramide is not separated into ceramide and galactose, so galactosylceramide will accumulate in the disease. Gaucher's disease is a beta-glucosidase enzyme or beta-glucocerebrosidase enzyme. So glucosylceramide or glucocerebroside accumulates here because that beta bond which is attaching glucose with the ceramide is not broken down. Look at the kind of similarity between a Krabbe disease and Gaucher's disease. It may kind of confuse you later because Krabbe is for galactosylceramide, Gaucher's is for glucosylceramide. Just remember that. So Krabbe, where galactosylceramide accumulates, that means the enzyme that is deficient is beta-galactosidase. Whereas Gaucher's, where glucosylceramide is accumulated, that means the enzyme is beta-glucosidase. So beta-galactosidase, beta-glucosidase. Beta-galactosidase is for Krabbe, beta-glucosidase is for Gaussian. Don't get confused there. Okay. And then we have niemann-pick disease. That's because of sphingomyelinase enzyme deficiency leading to accumulation of sphingomyelin. And finally, we have ceramidase enzyme deficiency that leads to accumulation of ceramide. So these are all examples for sphingolipidosis and the enzyme that is deficient and the lipid that is accumulating for each one of these sphingolipidosis. Now let's get into tay-sachs disease. Tay-sachs disease is also referred as GM2 gangliosidosis, which is a type 1 sphingolipidosis. Tay-Sachs disease is a neurodegenerative condition because of deficiency of beta-hexosaminidase A enzyme. Now note that this beta-hexosaminidase A enzyme, it is composed of two subunits, that is an alpha subunit and beta subunit. Exact stoichiometry we don't know, or it is not clear. Possible it is 2 alpha and 2 beta subunit. Anyway, so the role of alpha and beta subunit here. Beta subunit is the catalytic subunit. Remember that. So that's where is the conversion of substrate into product going on. That's where the degradation is going on in the beta subunit. Whereas the alpha subunit is needed for the beta subunit, especially to transfer the GM2 gangliosides to the beta subunit so that beta subunit can break N-acetyl-galactosamine from GM2 ganglioside. That's how the degradation is done. So now in the tay-sachs disease, what happens is there will be a mutation in HEXA gene which is coding for alpha subunit. Note that HEXA gene is for alpha subunit and XB gene is for beta subunit. So the defect in tay-sachs disease is mutation in HEXA gene. That means alpha subunit is not working fine or it is defective. Because of this, what will happen? The transfer of that GM2 gangliosides by alpha subunit to the beta subunit, which is a catalytic subunit, is not going on. Because of that, the hexosaminidase A enzyme activity is lost. A for alpha. Hexosaminidase uppercase A that is written there is alpha, means alpha subunit is defective. HEXA gene is mutated. Okay, so because of this, so hexosaminidase A is unable to remove N-acetyl-galactosamine from GM2 ganglioside, and that's why it results in GM2 ganglioside accumulation. That is why the disease is referred as GM2 gangliosidosis. And this disease is more common in Ashkenazi Jewish population and also French Canadians. Remember that. Now there are three forms of tay-sachs disease. One is infantile, the juvenile and late onset or adult form. Let's look at each one of them. Infantile tay-sachs disease. This is the most common and severe form of tay-sachs disease, where extremely low levels like less than 0.1% of beta-hexosaminidase A enzyme activity is seen. So the onset of signs and symptoms generally occurs 6 months after the birth with relentless deterioration in mental and physical abilities. The child may become blind, deaf, unable to swallow, muscles may get atrophied, paralysis can happen. So death usually occurs before the age of 4 years. Remember that. And also the most common cause of death is complications from lung inflammation. Usually it is bronchopneumonia. So that means infantile tay-sachs disease is the most severe form here. Coming to juvenile tay-sachs disease. In juvenile tay-sachs disease, the beta-hexosaminidase A enzyme activity is less than 1%. And the symptoms and signs usually begins between 2 to 5 years. And children, they develop cognitive and motor skill deterioration. They may have dysarthria, dysphagia, ataxia, dysphagia means difficult to swallow, ataxia means not able to walk in a straight line, spasticity, and death usually occurs between the age 5 and 15 years. And patients with this form typically they do not survive past their teenage years. So juvenile tay-sachs disease is relatively less severe form of tay-sachs disease compared to infantile tay-sachs disease, although death occurs here in this form of tay-sachs disease also. Coming to late onset or adult form of tay-sachs disease. Here, less than 10% of normal activity of beta-hexosaminidase A enzyme is seen. It's the least severe form of tay-sachs disease out of 3. And symptoms and signs appearing in the late childhood or adulthood. Usually it involves like clumsiness, muscle weakness, psychiatric disorders, gradual loss of motor skills, intellect and behavior becomes impaired in some cases, and the lifespan may be shortened or generally not affected. Now, coming to the diagnosis of tay-sachs disease, enzyme assay in leukocyte or cultured fibroblast can be done, and molecular genetic testing for 𝐒𝐽𝐴 gene can be done. Coming to treatment, currently there is no cure for tay-sachs disease, and there are no therapies that slow the progression of the disease. The treatment aims at relieving signs and symptoms and increase the quality of life. Coming to Sandoff disease. Sandoff disease, like tay-sachs disease, is a neurodegenerative disorder, but the deficiency here is affecting two similar enzymes. One is beta-hexosaminidase A enzyme and the other is beta-hexosaminidase B enzyme. So both the enzymes are defective here. Now in Sandoff disease, there will be autosomal recessive mutation in 𝐻B gene, which leads to defective beta subunit. Now when there is a mutation in 𝐻B gene, which is a defect in the beta subunit, then why both the enzyme activities are deficient here? Why it is affecting hexosaminidase A enzyme also? Because we have seen in tay-sachs disease, 𝐻A gene is mutated, which is coding for alpha subunit, and there will be decrease in the activity of only hexosaminidase A enzyme, beta-hexosaminidase A for alpha. Whereas in this disorder, 𝐻B gene is mutated, accordingly beta subunit is defective. But note that it is not just beta-hexosaminidase B for beta is defective. It is also decreased activity of hexosaminidase A enzyme also seen here. Because the reason for that is, as I already told you, the beta subunit is the catalytic subunit. So when beta subunit is defective, it also affects hexosaminidase A enzyme and hexosaminidase B enzyme, because for both the enzymes beta subunit is necessary. So that's why in Sandoff disease, because beta subunit is defective, there will be decrease in the degradation of GM2 gangliosides and globocyte. So that's why patients will show accumulation of both GM2 gangliosides and globocytes. So the infantile form of Sandoff disease is the most severe condition. Signs and symptoms appear at 3 to 6 months with muscle weakness, loss of motor skills, exaggerated startle reaction to the loud noises, seizures, changes in the vision and hearing loss, intellectual disability, cherry red spot and hepatosplenomegaly and frequent respiratory infections or bone abnormalities can be seen. Usually a child lives only into earlier childhood and death happens after that. The late onset form are usually milder than those that is seen in infantile in the previous slide. Late onset form of the disease, it includes presentation with muscle weakness, loss of muscle coordination like ataxia and other problems with the movement, speech problem, mental illness, this kind of issues can be seen. And the diagnosis again, like leukocyte or cultured fibroblasts for enzyme determination, or molecular genetic testing for HEX-A and HEX-B gene analysis. Treatment, just like tay-sachs disease, there is no specific treatment or cure for stand-up disease. Management is symptomatic and supportive. Now let's move on to see Gaucher's disease. Gaucher's disease is the most common of all lysosomal storage disorder. Remember that. If you consider all lysosomal storage disease, not necessarily Sphingolipidosis, it can be any lysosomal storage disorder. So, Gaucher's disease is the most common one out of all lysosomal storage disease. And the mutation is autosomal recessive inheritance pattern mutation in GPA gene. And this GPA gene coding for 𝐒𝐫𝐢𝐵𝐾 enzyme. So, there will be decreased or absent activity of 𝐒𝐫𝐢𝐵𝐾 enzyme in this particular disorder. That leads to accumulation of glucocerebrocyte, which is also called as glucosylceramide. This deposits in reticuloendothelial system of the liver, spleen and bone marrow. And the incidence of Gaucher's disease is high in Ashkenazi Jewish population. Note that even the tay-sachs disease incidence is also high in Ashkenazi Jewish population. Now, since glucocerebrocyte accumulates in the white blood cells, spleen, liver, kidneys, lungs, brain and bone marrow, so we are going to see something called as Gaucher cells in these organs. And the Gaucher cell has the distinctive appearance, as it is shown here in the figure, that there is a cytoplasm is blue-gray coloration with, there is a striations as you see here. Blue-gray with striations, that's the characteristic cytoplasm that you see in Gaucher's disease, and that is referred as wrinkled tissue paper quality. Wrinkled tissue paper or crumpled tissue paper appearance in the cytoplasm is a characteristic of Gaucher's disease. So, patient shows hepatosplenomegaly, bone marrow replaced by glucocerebrocytes. So, it may lead to anemia because of decrease in the red blood cell production like erythropoiesis decreased, thrombocytopenia because of platelet numbers decreased, leukopenia because of white blood cells decreased. So, anemia, thrombocytopenia, leukopenia. Patients usually bruise easily because of low platelets and experience fatigue because of low number of red blood cell where oxygen carrying capacity of the blood has decreased. Neurological symptoms include serious convulsions, hypertonia, myoclonus, dementia, ocular muscle apraxia. These are some of the signs that is seen with Gaucher's disease. So, there are three different types of Gaucher's disease classified according to the specific features and severity, and that is type 1 to type 3, and also it includes perinatal lethal Gaucher disease. Let's get into each one of them, little more details into each one of them. Now, the first one is perinatal lethal Gaucher disease. The perinatal lethal Gaucher disease, as the name says, it is the most severe form of all types of Gaucher's disease. Death usually occurs within utero or shortly after birth, just less than 3 months. There is no treatment for this severe form of Gaucher's disease. Gaucher's disease type 1, it is the most common form of all Gaucher's disease, and Gaucher cells build up in spleen, liver, bone marrow. Unless type 2 and type 3 Gaucher's disease type 1 does not usually involve the brain and spinal cord. That means the central nervous system generally is not involved in Gaucher's disease type 1. So, make sure you know that information. This is something which is different than type 2 and type 3 Gaucher's disease. So, type 1 Gaucher's disease generally do not involve the central nervous system there. These patients are at increased risk of Parkinson's disease, peripheral neuropathy, certain cancers and osteoporosis. Diagnosis is by measuring glucocerebrosidase activity or GBA gene genetic testing. Treatment, it involves enzyme replacement therapy like 𝐒𝐫𝐫𝐞, imiglucerase enzyme, tay-glucerase alpha, velaglucerase alpha, and miglustat. These are the enzyme replacement therapies that are currently available for treating Gaucher's disease type 1. Remember the specific enzyme replacement therapies for this disease. Coming to Gaucher's disease type 2. Again, glucocerebrosides accumulate in the spleen, liver, lungs, bone marrow, and the brain here. Symptoms usually develop by 3 months of age and include brain damage, seizures, abnormal eye movements, poor ability to suck and swallow, dysphagia, dystonia, encephalopathy, and hepatosplenomegaly. Many children, they die by 2 to 4 years of age, and Gaucher's disease type 2 generally does not respond to enzyme replacement therapy. That's something which is special here with the type 2 Gaucher's disease. Coming to type 3 Gaucher's disease. So it is a subacute neurological form of Gaucher's disease characterized by progressive encephalopathy, hepatosplenomegaly, bone marrow being involved in leading to cytopenia, with the age of onset of this disease being like childhood or adolescence. Neurological signs may include like supranuclear horizontal ophthalmoplegia, progressive myoclonic epilepsy, cerebellar ataxia, spasticity, dementia, and bone anomalies like osteopenia, which may eventually lead to pathological fractures or vertebral compression. Bone infarctions or even aseptic osteonecrosis can be seen in type 3 Gaucher's disease. And also patients with this disease will show that thrombocytopenia. Sometimes this thrombocytopenia may be severe, leading to bleeding diathesis, anemia, and less frequently leukoneutropenia. Polyclonal hypergammaglobulinemia is often present and sometimes complicated by monoclonal gammopathy. Now, Gaucher's disease type 3, the treatment involves imiglucerase, which slows the progression of the neurological symptoms and is effective against systemic manifestation. So, remember the treatment for Gaucher's type 3, it is imiglucerase. Now, there is a variant in the Gaucher's disease type 3 referred as type 3C variant. It is considered distinct because of its association with cardiovascular calcification. Remember that, can be an important point. So, type 3C variant of Gaucher's disease, it is associated with cardiovascular calcification, especially the calcification of ascending aorta and the aortic and mitral valves. That's something which is special or an additional point with Gaucher's disease type 3C. It's the variant of type 3 Gaucher's disease. Coming to Fabry disease. Fabry disease, also referred as diffuse angiokeratoma, which is also referred as Anderson-Fabry disease. It's an X-linked recessive condition. That's a special point with Fabry disease in terms of inheritance pattern. Mutation is in GLA gene, which is coding for alpha-galactosidase A. And this alpha-galactosidase A is the enzyme that handles degradation of ceramide trihexoside, which is also called as globotriacylceramide. Because of the deficiency of alpha-galactosidase A enzyme, so there will be accumulation of this ceramide trihexoside or globotriacylceramide. And this accumulation is generally seen in blood vessels and other tissues and organs. Now, the kidney complication is the common and serious effect of this disease, and usually patients die because of renal failure. Other than this, patient may show hypertension and cardiomyopathy, And pain is one of the more common symptom of Fabry disease, and usually that is the first sign that brings patient to a physician's attention. Something called as Fabry crisis is seen in Fabry disease. It is the experience of the intense excruciating burning pain which is felt initially in the hands and feet and later it radiates to other parts of the body. That is what is called as Fabry crisis, which is seen in Fabry disease. Other than the pain, patient will show angiokeratomas. These angiokeratomas are tiny painless papules that can appear on any region of the body but are predominant on the thighs, around the belly button, buttocks, lower abdomen and groin. That's why Fabry disease is also referred as diffuse angiokeratoma. Diagnosis is done by enzyme assay in culture fibroblasts or genetic testing, which is done both in males and females, because males are the ones who are symptomatic and females act as a carrier. Now treatment includes migalastat, and this migalastat increases the activity of alpha-galactosidase A, and then A-galactosidase alpha. This treatment, it reduces the accumulation of 𝐒𝐫𝐢𝐵𝐷, especially in the capillary endothelium of kidney and certain other cell types, thereby decreases the signs and symptoms. And then the Fabry crisis can be treated by giving phenytoin, carbamazepine, gabapentin. Then AC inhibitors can be used for renal impairment, and in the end stage renal disease treatment can be hemodialysis or renal transplantation. So these are some of the treatment approach to Fabry disease. And you see here, this is the figures that shows angiokeratoma. As you see, these are painless papules which are nothing but dilated blood vessels which contains 𝐒𝐵𝐢𝐵𝐷 or ceramide trihexoside. Our next disease here is Farber disease. Farber disease is also referred as Farber lipogranulomatosis. This is an autosomal recessive condition because of mutation in ASAH1 gene, which leads to deficiency in ceramidase. So here in this disorder, ceramide accumulates in various tissues that include joints, central nervous system, throat, liver and other organs. Signs and symptoms typically appear in the first few weeks of life, and that includes hoarseness of the voice or weak cry, hoarse voice or weak cry due to soft floppy voice box, that is because of laryngomalacia, and small lumps of fat are found under the skin and in other tissues. That is what is referred as lipogranulomas. That's why the name of the disease here can also be called as Farber lipogranulomatosis. And also there will be swollen and painful joints, joint contracture, arthritis can be seen, and patient may show developmental delay along with hepatosplenomegaly. So these are some of the signs that we see with Farber disease. So remember, hoarse voice, weak cry, and then lipogranulomas beneath the skin, and joint contracture, joint pain. Alright, so there are 7 types of Farber disease have been described, each with slightly different characteristics. Just to name type 4 and 5. So type 4 and 5 generally associated with severe neurological problems. So treatment, there is no definite treatment available at this time. Currently, treatment is focused mainly on managing the symptoms. Coming to Krabbe disease. Krabbe disease, again, it's an autosomal recessive condition because of mutation in a gene, that is GALC gene, which is coding for beta-galactosylceramidase or beta-galactosidase. Beta-galactosidase enzyme, it degrades galactosylceramide and deficiency of this enzyme will lead to accumulation of galactosylceramide and mainly in the nervous tissue, because galactosylceramide is present at high quantities in the nervous tissues, and especially it is sulfated. Now, infantile Krabbe disease is most common and severe form of this condition. Approximately 85 to 90% of people affected with Krabbe disease have their infantile form, which is characterized by the irritability, hypertonia, sensitivity to loud sounds, like which is referred as stuttle response, and then they will show developmental delay, unexplained fevers, vision loss, peripheral neuropathy, seizures, hearing loss. This is what is seen in the infantile form of Krabbe disease. Whereas the signs and symptoms in the late onset form is extremely variable, but may include muscle weakness, rigidity, walking difficulties, vision loss, intellectual regression, and seizures. Coming to treatment, there is no cure for Krabbe disease currently. One of the things that is tried is hematopoietic stem cell transplantation, that is umbilical cord blood stem cells, seems to be promising in some cases of Krabbe disease. Just have an idea on that part. Now coming to niemann-pick disease. Niemann-pick disease can be divided into type A and type B. Let's look at type A first. Niemann-pick disease type A is an autosomal recessive condition because of mutation in SMPD1 gene that leads to absence of sphingomyelinase enzyme. Note that sphingomyelinase enzyme, it degrades sphingomyelin in the neuronal tissue into ceramide and phosphocholine. So because of the absence of sphingomyelinase, so sphingomyelin accumulates in the spleen, liver, lungs, bone marrow, and also most importantly the brain. So type A niemann-pick disease is more severe and the age of onset is early. So disease manifests during infancy and it is characterized by hepatosplenomegaly, failure to thrive, progressive deterioration of the central nervous system. Due to involvement of the neuronal system here, so niemann-pick disease type A is also known as a neurological type. There is no effective treatment currently available for this condition, and those who are affected generally do not survive past early childhood. So it's a severe form of niemann-pick disease. Coming to niemann-pick disease type B. This disease is similar to niemann-pick disease type A, but it is due to deficiency of sphingomyelinase rather than absence of sphingomyelinase that is seen in type A. Typical signs and symptoms develop in pre-teen years and may include hepatosplenomegaly, short stature, frequent lung infections, low number of platelets and white blood cells leading to thrombocytopenia and leukopenia. Bone abnormalities, osteopenia, cherry red spot, ataxia, dysarthria, dysphagia, dystonia, supranuclear gauge palsy, all this kind of neurological issues can also be seen in this disease. Gradual loss of intellectual disabilities which may lead to dementia and seizures. And also niemann-pick disease will show a characteristic foam cells present in the bone marrow aspirates and also seen in monocytes and macrophages. So the foam cell appearance is shown here in the figure. Coming to metachromatic leukodystrophy. Again, this is an autosomal recessive condition because of mutation in ARSA gene and PSAP gene, which are coding for aryl sulfatase A enzyme and also prosapposin proteins respectively. Now the sapposin proteins like sapposins A, B, C, D proteins, they help lysosomal enzymes to break down sphingolipids, and especially sapposin B protein is associated with enzyme aryl sulfatase A. So deficiency or defect in aryl sulfatase A or prosophosin will lead to accumulation of sulfatides in the cells, especially the cells of nervous system. So this accumulation results in progressive destruction of white matter of the brain. That's where most of the sulfatides are found. And the affected individuals experience progressive deterioration in the intellectual functions, motor skills, such as ability to walk. They also develop loss of sensation in the extremities, incontinence, seizures, paralysis, inability to speak, blindness, hearing loss. It is an extremely neurological signs and symptoms that you see here in metachromatic leukodystrophy. Multiple sulfatase deficiency is because of mutation in SUMF1 gene leading to defective formyl glycine generating enzyme, that is referred as just FGE. This formyl glycine generating enzyme is found in the endoplasmic reticulum, which is involved in protein processing and transport. And the formyl glycine generating enzyme, it modified sulfatases. Decrease in the activity of sulfatases here because of the FGE enzyme mutation leads to accumulation of sulfatides in the brain, skin and skeleton. It will lead to signs and symptoms similar to aryl sulfatase enzyme deficiency. The neonatal type is the most severe form of the disease, with symptoms and signs developing soon after birth. And the late infantile type is most common form and usually presents with progressive loss of mental abilities and movement after a period of normal development. And the juvenile type is rare with a slow regression of psychomotor development in mid to late childhood. Life expectancy is shortened in all type and there is no cure for multiple sulfatase deficiency currently available, and treatment includes physical therapy and supportive services. So these are all Sphingolipidoses. I hope this lecture has helped you in going over this very important concept in biochemistry, where all the clinical disorders related with sphingolipid degradation, which all belongs to lysosomal storage disorders. Thank you.